think it's particularly going to be useful for people who are new. And also, I think it takes a lot of processing to understand what JIA actually means. It takes years. So I think this talk is going to be good from the point of view that it's going to iterate and reiterate stuff that you might know already or need more understanding on. I've just lost Shehnaaz over here. Oh, here she is. Okay. I'm going to hand over to Shehnaaz now because I think she's got a lot to say and we need to end at 9 o'clock. So she's going to talk to us and then Shehnaaz, there'll be some time for a Q&A.
Yes.
Okay, great. So some of you know Dr. Shehnaaz. She is a pediatric rheumatologist. And I've heard that she is wonderfully empathetic and incredibly knowledgeable. And I think that having someone who is knowledgeable and empathetic and can give us a talk tonight with a whole lot of information is a powerful tool to have because this journey is filled so much with uncertainty. I think it's so important to have somebody who you feel safe with. And that's why I'm really excited about this talk tonight. Shehnaaz, I believe, loves chocolate. I believe she's an outdoor enthusiast. Did I mention she's got 3 kids of her own? And coffee. She loves coffee, I believe. Okay. So over to you, Shehnaaz. You're on mute.
Yeah, thanks.
Great, thanks.
Thanks, Laura. Good evening, everyone. And I can see quite a few people that I do know. And I'm hoping that this is just revision for the moms and dads of my current patients. And the pitch is going to be pretty basic because that's kind of our first video on this. We're trying to get like just a simple message across about what juvenile arthritis is about. And it's the first of hopefully many. And so hopefully it's revision, but there will be time for questions. And so if there are some burning questions that are a bit more in depth or further down on the journey, we can answer them. So I'm going to start sharing my screen. I'm not the most technologically savvy person, so some of you may know that. And you're just going to bear with me. I also like when I'm nervous, I kind of use a bit of humor. Okay. Can everyone see the screen? Laura, is that okay?
Yeah, I can see well from my side. Everyone else? Just shout if you're struggling. Also, you can maybe I don't if you're on your phone or if you're on your laptop, you could also maybe play around with settings a little bit. You might want to see more of the screen, or you might want to see more of Shehnaaz. So you can just play around with the Zoom settings a little bit. If you chuck yourselves out of the room, just come back in and come into the waiting room and I'll admit you again. And then also, I mentioned if possible, if you can put your screen on so that we can see you, because it's just so nice to see each other and to be in our community together. Thank you.
Okay, so yeah, I've just titled Understanding Juvenile Idiopathic Arthritis, the Basics. And the lovely caption that's in Arthritis Kids was that kids get arthritis too. And that's kind of also on my t-shirt that Laura's kindly given me. And so you can see from that statistic, 1 in 1,000 children develop arthritis, and it's probably 1 to 4 in 1,000, which is actually quite a high incidence of children. If you think of type 1 diabetes, it's probably about the same amount. And people know about type 1 diabetes. Often people don't know at all. Like I often have parents, saying that my child's thirsty a lot, and so do they have diabetes? And so that's something that's already in some people's frame of reference, where arthritis is often never in someone's frame of reference. So just to kind of break the ice, we're going to play a bit of a game. I don't know if any of you know, on KFM, they have this thing where they have words with like a sound, like it's called a phenome. So the sound is room, and I'm just going to go through. If anyone wants to answer, you're welcome to, but it's pretty easy. So I want you to guess. So a place where you sleep. Anyone can give me a quick answer?
Room.
Yeah, a room or a bedroom. Okay, next one. The male that is getting married.
Groom.
The groom. A sound that a car makes.
Room. Room.
Vroom, vroom. What do you sweep with?
Room.
Okay, last one. A famous Turkish Sufi poet.
Rumi.
Yes,
Rumi.
nice one. So, I mean, there's a nice quote that Rumi says, the pains that you feel are messengers, listen to them. And so, I mean, these also obviously important for our kids because children often shouldn't be feeling, excuse me, some of these pains. And then, who is your child going to be referred to when your doctor is concerned about swollen joints for more than 6 weeks? A rheumatologist. That's our final room. Okay, and so obviously no one's ever heard of a rheumatologist. So just a little bit of history. The word rheuma comes from a Greek word. There's a lot of like our medical terms come from Greek or from Latin, and it came from a previous misconception that aches and pains were essentially flowing. And I mean, there is possibly some sort of understanding to that pains flow through the body, and so that's what rheuma meant. Rheuma meant things that flow. But in the early 1900s, rheumatologists were eventually kind of classified as joint specialists because they were mainly seeing gout, osteoarthritis, and rheumatoid arthritis. And it was mainly sort of joint issues. But in the mid 20th century, so it kind of shows how relatively new this discipline is, it wasn't just about the joints and wear and tear. It was actually what was underlying this, and that was the immune system. And that was kind of a turning point. So rheumatologists weren't actually joint doctors, but specialists in autoimmune diseases. So some of the conditions we see don't necessarily have joint involvement. Lots do, but it's the underlying problem is the autoimmune system. And so, and again, as our science is evolving, we knowing and we're understanding that a lot of previously unknown conditions are actually driven by the immune system. And so there's a lot of overlap between, brain conditions and autoimmune disease, and previously thought lung conditions that actually the nature is autoimmune. So that's essentially the kind of spectrum of patient we see. But in pediatric rheumatology, the main sort of bread and butter disease is juvenile idiopathic arthritis. So JIA for short, as I'm sure many of you know, and juvenile is the J, so it's obviously a child less than 16. The idiopathic is essentially we're not really sure what the exact cause is. We could say that TB, tuberculosis, is caused from this bacteria, Mycobacterium tuberculosis. Where juvenile arthritis, we can't pinpoint and say exactly what the cause is. And the A for JIA is arthritis, so that's inflammation in a joint. But the definition takes into account that the fact that you may have other causes of arthritis, inflammation in a joint, that's not from a chronic condition or a long-term autoimmune condition. So we have something like septic arthritis, where there's actual bacteria in the joint, or a reactive arthritis, where the immune system reacts. So the definition has the 6 weeks in place so that we don't also overcall other causes of arthritis. And again, you can see it's about 1 to 4 in 1,000. We say it's a diagnosis of exclusion, and I'll just kind of get into that just a little bit further down. But from my point of view, it's a diagnosis of exclusion because someone has thought about it and referred the patient to me. But for a general sort of pediatrician or GP or orthopedic doctor, we want it to actually be a diagnosis of inclusion, so that they're actually considering juvenile arthritis. But when we do blood tests, we often are trying to exclude other causes. And so we often get normal bloods in juvenile arthritis. And then sometimes people actually refer to like the children as the walking wounded, because some children have relatively painless joints, or the swelling is present, but it's only picked up when there's a fall, or that they've been sick and they've got a fever, and then as a parent you kind of put a little bit more emphasis on looking at the child, and then you see a swollen joint. And so the most classic way I get referred patients is after a fall, where the patient has fallen and perhaps they're clumsy because their joints are swollen. And so then obviously everyone looks at the joint and thinks, oh, it's a fracture. And so they go via the orthopedic route. So we obviously can't understand juvenile arthritis unless we kind of have a bit of an understanding of what's happening in the immune system. So I'm just going to briefly kind of give you what's the two big parts of the immune system. And then you can see that's a very well guarded president's house. And in the immune system, we have something called the innate immunity and the adaptive immunity. So the innate immunity is your body's physical barrier, or a chemical barrier, or the first cells that come and defend. And we would liken that to the fence, or electric fences, or security guards that's standing right at the border of a door. Chemical barriers in our bodies would be, things like secretions, snot, the tears in your eyes. And then cellular defenses are your first line cells that, essentially fight and cause a bit of a fever, cause increase of the secretions. So that's like your first line immunity, and that's called innate. And they say innate because that is, you're kind of born with those features and those immune cells. The next part of the immune system is called the adaptive immune system. And that there's two ways in which you can develop an adaptive immune system. One is passive immunity, and that is during like child in the third trimester, moms send a big amount of their own antibodies across the placenta to the developing baby. And the other is breast milk, which is why breast milk is so important, because you're passively giving immune cells to your baby. And then artificial is when we are giving vaccinations. So we're passively trying to get the immune system to develop antibodies. And then the active immune system is also naturally where we come across bacteria and viruses, and our body engages with those things and builds an immune system and immune cells. And the other is also vaccinations as well. So the one type of vaccine is you actually giving the antibodies, and the other is where you're giving a portion of say, chicken pox, and your body then develops the immune cells to that. So these are just kind of like the actual cells that are involved, and there's a little bit of an overlap, and that overlap is the communication between the two. So our first cells of the innate immune system, which is the immediate immune system, are things like your mast cells, neutrophils, and monocytes. Those are the first defenders. They are what we would say in like our analogy of the president's house. That would be like your first security guards, your dog that is going around and sniffing for something that's foreign. And those cells pick up things and then respond immediately. But they also then send signals via, if you look at the middle compartment, your dendritic cells, your macrophages, they send communication to the other part of the immune system, the adaptive immune system. And those communications are, if we look back at our picture of the president's house, would be your sort of alarm system. If you look at the picture here, there's like a sniper right on top there. Your sirens. So those send off signals, and they activate both your B cells and your T cells. And for our purposes, this is kind of where the problem of autoimmune disease lies, is in your B cells and your T cells. So your B cells are what produces antibodies, and your T cells produce these other cells called CD3, CD4, CD8, and they, in combination, develop antibodies and fight through different mechanisms to protect the body. They also speak to each other. So the B cells and the T cells communicate through other chemicals to each other. And then there's a lovely cell called the T regulatory cell, which is down here, which is supposed to regulate things and say when enough is enough, essentially. So once you say you have a virus or bacteria that comes in, your body mounts this immune response, and then your body is supposed to switch it off at the same time. So as you can see, the whole pathway is so intricate and so diverse that no one really can have the same expression of disease, because there's so many cells that are taking part in your immune system. And it really is beautiful, because most of the time this is working seamlessly, where your body is just protecting you from bacteria and viruses and working with the innate and the adaptive immune system. But obviously until we sometimes have a problem. So just a word about antibodies. So those are more specialized cells. And so I'm going to flip back one more to your B cells. So your B cells are then activated and they make antibodies. And your antibodies are very specific. They are specific things that are created to target specific, the word is antigens. So like in this picture, Spider-Man knows how to kill venom. I don't really know. I think the other one's Thanos, and that's like the person for Iron Man. And I don't really know who the middle guy is. But your antibodies are cells that are very specific to certain things. But unfortunately, in people with autoimmune diseases, this is one part of the immune system that can be dysregulated. So the body makes in error antibodies, not only to, venom and Thanos and the baddies, but the body also makes antibodies to self. So like that's, if you look at that, it's the body's immune system looking at self. And this diagram is quite a nice little simple diagram where it's the little yellow cell is saying, but I'm one of you. And so the body, in essence, makes a mistake and attacks itself. Now, obviously, the big question is why? And that's, we're getting a bit more understanding on the why. So if we start in this diagram and we look at the immune system, so if we talked about my previous slides of how intricate the immune system is, on any part of that system, there can be a problem where the body misfires and signals that there's a problem in error. Sometimes the immune system has been activated because there was a virus. Sometimes the body's immune system, the regulatory cell is not switching off the system. Sometimes there's something called self-tolerance. So when you in the mother's womb, your body goes through your immune system goes through this amazing system of recognizing self. So your body almost scans every single cell. Your immune system scans every single cell and says, this is me, cool, I don't have a problem with you. This is me, I don't have a problem with you. But when one of the cells has a problem with a self cell, the body is supposed to wipe it out. And sometimes that doesn't happen. And so you have a problem of self-tolerance. So that's the immune system, where the immune system can be dysregulated. Then we know that there's genetic predisposition. So some families have within their families a history of different manifestations of autoimmunity. So someone's got psoriasis, someone's got lupus, someone's got rheumatoid arthritis. Someone's dad has back pain, and that we would say would probably be the genetic predisposition. And there are more and more genes that we are picking up and we're understanding that are involved in the immune system. Then we go to the environmental factors. So that would be things like your exposure to exposures to certain infections, and certain infections predispose to more autoimmunity. So things like Epstein-Barr virus, I don't know if anyone of you come across that, EBV, some of the other strep pneumonia can predispose to autoimmunity. So there's environmental factors. This is also the group where they do lots of studies and they do big, large studies. They pick up these correlations. So antibiotic exposure is one of the correlations. Children who have been breastfed and not breastfed, children who've been born via Caesar, non-Caesar. And that all speaks to the exposure to bacteria and non-bacteria. And then the last thing is hormonal factors. We know that autoimmune diseases occur more commonly in females, especially after the age of 12. After puberty, there's a much higher increase of female to male ratio. And that's, again, coupled with a few factors. One is the actual X chromosome itself. So when we say women have a stronger immune system and there's something like man flu, it's probably somewhat genetically understood, because the X chromosome is where the coding for the immune system is. And so men obviously also have an X chromosome, so they're coded by their one X chromosome. And females have two X chromosomes. And so we're supposed to only have a single dose of immune response, but sometimes our body doesn't switch off the other X chromosome, and so we almost have a double response. So that's the one kind of understanding why women have more autoimmunity, but also estrogen plays a part as well. So as you can see, there's no one cause, which is still why we're kind of in the group of idiopathic. There's certain correlations, there's certain things that we've understood where there's a gene that's present, but then the theory for if it's only a gene, then why a sibling with the same gene doesn't have it, or another female sister of the patient doesn't have arthritis. So it really is an interplay of all of these factors that lead up to autoimmunity. So I hope I haven't lost and confused you all at 8:30 at night with all this. Okay, so let's just talk about what we're talking about, the joint. So I'm going to just zoom in on the normal joint. And so it's quite nicely labeled here in the normal. So when we're talking about a joint, we are talking about almost the tissue that surrounds the two bones that meet. So whenever there's a bone and the bone meets, there's a joint. And the body has different types of joints in our body. Most joints will have, where the one bone meets the other bone, there's a layer of cartilage. Then surrounding that is the synovial tissue, or the synovial membrane. And that is the tissue that's often the area where the body is attacking. So if you look at the healthy joint, you'll see, obviously, we see the one bone, your femur coming down and your tibia coming up. It's labeled cartilage. And then synovial fluid is the joint fluid. Then we're going to go to a joint affected by inflammation. So as you can see where it's like labeled bright red inflammation, that is the area within the synovial membrane, the actual tissue that's inflamed. You'll see it says excess synovial fluid, and that's extra fluid that's been made by the synovial membrane. And the two other things that's labeled there is bone overgrowth and thinning cartilage. Okay, so now those are things we actually want to hopefully prevent. So what is happening is the body is causing inflammation for whatever reason, like we went through. The body's immune system has been activated, it starts fighting, and it causes pain, extra fighting cells to come to the synovial area. And this tissue, the synovium, which is responsible for keeping the joint healthy, responds by making extra fluid. And so that's often why you get swollen joints. But the body, along with its inflammation, also wants to heal and build. And so what happens is you can then send extra blood to those areas, and extra blood often means extra growth. And so you can end up with bone overgrowth at a place of that's been affected. So it's slightly different to patients who have muscle problems, because often when you have muscle problems, you're not using the area. So the area gets, like the word is wasted, like it obviously gets, the tissue gets less. And so the unaffected side is often bigger, and the affected side in a muscle condition is wasted and thinner and looks smaller. Where that's slightly different in juvenile arthritis, because here the affected side is actually getting more blood flow to sort of fight. And so you can have overgrowth of the bone, you can have overgrowth of the synovium, and the whole area sometimes can look a bit bigger. And so that is what we're actually trying to prevent when we're trying to treat juvenile arthritis quite early. Is we don't want to have overgrowth. We also don't want there to be thinning of the cartilage. So in the synovial fluid, you have cells that are fighting, and it's almost causing collateral damage. So it's thinning the cartilage. In pediatrics, we obviously don't really want to ever see erosions in the bone. I mean, also in adults, you want to see that. But in pediatrics, that's why we often don't do, like the x-rays aren't as helpful in comparison to adults, because there hasn't been time to develop the erosions of the bone or the narrowing of the joint. So I'm going to move on, but we obviously can come back to this if people want to go into it. So like I said, we're doing just like a very basic overview. So in this kind of discussion, we're not really going to go into the treatment or like the full detail of the investigations, but I'm sure in your reading, you may have come across the different subtypes of juvenile arthritis. And this is an umbrella term. And again, we've gone through what JIA stands for. And it's broken down into different grouping. This differentiation of types of arthritis may change. And the reason why it may change is because these are almost pattern recognition. And the more we knowing about juvenile arthritis, the more we know about the different genetics and the different markers, the grouping doesn't fit as nicely. But for now, this is what we use under an umbrella term of juvenile idiopathic arthritis. And I'll just go through them briefly so that we kind of, when your doctor says your child has systemic onset JIA, you kind of understand what that is as a different to psoriatic juvenile arthritis. So we'll start with oligo. So oligo JIA is essentially less than 4 joints. From oligo JIA, the oligo again is a Latin word for like less. This group of patient is often ANA positive, and ANA is an antibody. Like we spoke about earlier, your body can in error make antibodies. This is just a picture to show you from the back that if you can appreciate on this side, that this ankle is slightly more swollen than the right ankle. And it also looks a little bit longer. The group of patients who have oligoarticular juvenile arthritis often have a higher risk of having eye involvement. And we're not exactly sure why the eye is specifically involved with especially the childhood version of juvenile arthritis. We know the antibodies and we know where the area of the eye is, but the full understanding of what the link is in terms of the eye and the joints is not fully understood. The area of the eye that we're looking out for when we refer patients to the ophthalmologist is the uvea, and what we're looking for is uveitis. And this is just a diagram to show you the different parts of the eye. And the uvea is like a membrane that covers right from the beginning of the pupil I'm trying to pointer. You'll see just by below the pupil, there's like the first marking that says uvea, and that goes all the way from there, all the way to the back where it says optic nerve and around. So it encompasses the whole sort of back of the eye, including a little bit of the front. And the ophthalmologist will, look firstly just on examination with a light, and then they use a slit lamp and they look at the back of the eye to see if they can see anything on the uvea. But they also look to see in that big chamber, which it says vitreous humor, they're looking to see if there's any extra cells, white blood cells that are not supposed to be there. And they literally, at the beginning, if they find uveitis, they're actually counting the number of white cells they can see. So that's why we encourage screening early, because that kind of stuff, no one will pick up. I mean, I, for certain, won't pick up on an examination. And often little kids are not going to feel anything in their eyes, and they're not going to really understand if they do feel blurriness or they do feel a little bit of, it's not really particularly painful at the beginning. So we, especially for this group of patients, the oligo who are ANA positive, we very much want them to be screened regularly. So yeah, it's a mandatory eye screening. This is just a picture to show you. I mean, anyone can pick up, but this means that the eye is already complicated. There's already been damage to the eye. You can see the pupil here is not round, and there's like little white specks on the eye. So obviously we're trying to prevent that. We don't want. I mean, obviously I would never want to be able to see that, because that means that this would be uveitis that's missed. So that's the oligoarticular group. And this group is the biggest group that is the childhood arthritis. This, if you could look at the chances of going into remission, it's the oligojuvenile arthritis group who are ANA positive. Okay, then now we go on to polyarticular JIA, and that is more than 5 joints. And here it's broken down into 2 groups, rheumatoid factor positive and rheumatoid factor negative. And rheumatoid factor is also just an autoantibody. Our polyarticular juvenile arthritis have the pediatric group. So they can present as little kids. And then our next big time of the polyarticular is when they're in their teens. And this group of patients are the ones who possibly will carry on to become adult rheumatoid arthritis. But what we want to do is we want to prevent damage to the joints. And so you can see, I mean, the picture of the hand, there's already quite destructive joint damage on the wrist, on the hand, the knees are overgrown. So they have a combination of small joints and large joints. And what differentiates this group is the rheumatoid factor and the number of joints. Our next group is the enthesitis-related arthritis. And this group of patients are often boys. They have the HLA-B27 gene that is positive, bearing in mind that about 10 to 20% of the population who are healthy will also have HLA-B27 positivity. But if you look at the group of patients who have enthesitis-related arthritis, there's about a high chance of them having the HLA-B27 positive. About 70% of patients will be positive for the gene. And sometimes these are actually the more tricky ones to diagnose. Because I'm going to zoom in on the picture, because you can see that the area that's affected in this type of sort of arthritis is not the actual, what we looked at earlier, the synovium, not the joint. And you can obviously, it's where the red arrows are pointing. It's at the insertion points of the tendons or ligaments onto the bone. And so these children often don't have swollen joints, but they have multiple sites of pain. And so they sometimes, only get diagnosed much later on in life because, they don't have anything to show for it. They're in lots of pain, but it's very random. And these are also sites that commonly can be painful if you've exercised, or they can be painful in runners or sportsmen. You'll look at this boy here on his knees. that's a classic point for sort of shin pain or shin splints or kind of growing pains. And so these patients, we heavily actually rely on imaging for them, on MRIs, because it's very difficult to, fully say, is this an active area of inflammation? So they often have hip involvement, they can have ankle involvement, they have the midfoot because there's lots of sort of insertion points. And then the other thing is the enthesitis. So the enthesitis, like I said, is the insertion points onto bone and ligaments which have inflammation. And these children can become, or if they're missed when they're younger, they present as adult patients, and the word is ankylosing spondylitis, quite a heavy word, and they can have back involvement when they get, and that's how they get diagnosed as adults. So they're often enthesitis-related arthritis when they're children, and later on they can be ankylosing spondylitis. And these children often have quite a lot of pain. So as opposed to the oligoarticular, the little kids, they often have, a little bit swollen joints, but their pain level is not so high. This group of patients have extra stiffness and a bit more pain. Our sort of last subtype before we get to the systemic juvenile arthritis is the psoriatic juvenile arthritis. And this is the sort of classic condition that just blows the whole kind of categories away, because often patients with the previous type of arthritis can have psoriasis. The psoriasis can also occur in the oligo group, and so the lines get a bit blurry. But from a classification point of view, these are children that often have a family history of psoriasis, so either a first-degree relative, mom or dad, or a sibling who has psoriasis. They have something called dactylitis, and you can see in picture A, like we have a swollen sausagey toe. That's what dactylitis is. They can have nail changes. They can also have the small joints, like the polyarticular children, and they can be ANA positive. So this would be the patients who we categorize as psoriatic juvenile arthritis. And psoriasis and juvenile arthritis are quite closely linked. And again, like a family member with psoriasis, a first-degree family member has a higher chance of a child having juvenile arthritis. And again, that kind of tells you a bit about the genetics, because if a family member has psoriasis, which seems to be inflammation of the skin, how is it that the child has a higher chance of arthritis? So there definitely is genes kind of in play here. Just for clarification, psoriasis looks very similar to eczema. Sometimes the sites are slightly different. So, often parents will say, like, I thought my child had cradle cap. And, when they're older child, you're not supposed to be having cradle cap. Or it'll be behind the ear or at the ear piercing, by the belly button. And then they can also have fingernail changes as well. So sometimes it's very subtle, the psoriasis, bit of flaky skin here and there. And then when you look slightly deeper, actually the pattern fits. And then the last group is systemic onset juvenile arthritis. And I want just to take you back to the first picture of the immune system, the innate and the adaptive immune system. So systemic onset juvenile arthritis fits under the umbrella of juvenile idiopathic arthritis, but the area of the immune system that's affected is not actually the same as the other types of juvenile arthritis. Here, it is the beginning immune system that's being activated and being switched on. And so these children are often, as you can see this picture of the temperature chart, have high temperatures. It's often a classic once-a-day temperature, quite irritable at the beginning of diagnosis. They're lethargic. They look actually sicker than the other children. And so they often get initially misdiagnosed as having a flu or a viral infection. They can have swollen glands. there can be a lot more other involvement in the body. So the underlying part of the immune system that's been awoken is different to the rest of the other arthritises that we've been speaking about. This is the innate, the beginning immune system, your immediate defense, the walls, the first security guards. They are being triggered. And again, we're not sure why they're being triggered, but they're being triggered and they're having this rash and fever and a child that looks like they have an infection. And so these children, when they first get diagnosed, it is quite difficult because their bloods also look very abnormal, as opposed to all our other types of arthritis. When we do bloods, it's, the bloods can be normal. The systemic onset juvenile arthritis, the bloods are abnormal. And it is also important for us to differentiate between this type of juvenile arthritis and our other type, because our treatments are different. So I'm going to just move on to our way forward. So we want to move away from the Oprah picture that I have, where it says everyone gets steroids, you get steroids. We do prescribe a lot of steroids, unfortunately. But the more and more we're learning about steroids, the more and more we know how harmful they can be in the long term and in the short term. So steroids work beautifully in calming down inflammation really quickly, but they have a lot of side effects. And so, if your child's given a course of steroids, they're given a course of steroids from me, it's very purposeful, because we know that the side effects that are associated with steroids. But we also know that the sooner we diagnose and the sooner we treat, there are improved outcomes. There's lots of studies, and the way forward is what we call a treat to target. So we want to have goals in which we're getting reduction of pain, reduction of joints, obviously not being on steroids. And if we're not meeting our target, we need to then move forward and adjust treatment, because there's many reasons why we need to treat. I've kind of showed you a picture of the joint getting bigger. There can be joint damage. Importantly, children can have pain, and we don't want any child to be in pain. We don't want any child to be limited in their ability to do things. And so we really do push for early diagnosis and aggressive treatment. And sometimes it's quite difficult, because obviously first you're coming to terms with the diagnosis that was never in your radar, and then medications that sound horrendous, with lots of side effects. And obviously ChatGPT and Google and all these things often paint quite dire pictures of these medications. Alongside the medications, we obviously want to encourage healthy lifestyles, exercise, mental well-being of children, and vaccinations. And obviously the vaccinations are with a huge caveat to be checked with your doctors. Ophthalmology. So it is a kind of a big multidisciplinary team that needs to get involved. Often we rely on radiologists to help us a lot with it, and to have a good radiology team, and then support organizations like Arthritis Kids, because firstly, from a family support point of view, from a parent support point of view, for a child/teenager, especially the teens. So that's the one massive role that Arthritis Kids plays. But the other huge role that I lean on a lot is the part against the funders. And so I just want to say thanks to our patients, who are the real superheroes in the story. And I'm going to end my slideshow. No, not there. And I think I'm back.
Yeah, you are.
So there was like a whirlwind of the immune system and juvenile arthritis. So the nice thing, obviously, it's recorded, so you'll be able to kind of go through the slides and just at your own pace, just look at the pictures and kind of understand the different subtypes. Because it is important, because often that people ask you, like, what type of arthritis do you have? Or when we classify in terms of the medical aids, we classify under the umbrella of juvenile arthritis. We don't need to subclassify. But like I say, we can't, like right now, I suppose we're limited by time to go into now like the next steps in terms of treatment and a bit more detail in terms of investigations. So I don't know, Laura, are you going to screen questions, or
Yeah, that's okay.
if anyone has anything burning, or if I just confused everyone totally?
No, for me, this was very clear, and I learned a lot from this. So thank you. If anyone needs some clarification, now's the time to ask. And if you have any questions, please do. We've got 10 minutes left. So you are most welcome to put up your hand and ask. If anyone wants to just jump in there, just go for it. Yes, Kath.
Hello, Shehnaaz. Hello, Laura. I had a question, and it's a question that I've asked a couple of rheumatologists actually. The idea that it's one form of a disease in a child, and then it sort of is it just a renaming, or has the disease actually changed? Does it change as the child ages? Does it go from being, an umbrella juvenile idiopathic arthritis to being ankylosing spondylitis, or is it just this is a funding issue and this is what they call it in adults and it's got a different name? And I've never quite understood that.
Yeah, so that's actually where the classification is problematic, because the purely pediatric version is oligo, articular juvenile arthritis. And each of the other ones have adult-like counterparts. So the systemic onset juvenile arthritis is named Still's disease as an adult, but it's the same thing that's happening in the body. So it's almost that kind of siloed treatment of pediatrics and adult medicine. Like lupus in a child is the same as lupus in an adult. It doesn't change in terms of its naming. So I think it's more a funding issue rather than the pathology changing over time. It's more likely that when a child presents in their teens, that's the adult kind of manifestation just presenting in a juvenile setting. But I think it's and again it's the problem of the naming. It's not a different disease.
It's tricky though, because as your child ages, the adult rheumatologist wants to rename the disease, and then it comes with a different ICD-10 code, and then you've got funding issues. So I've always, okay, so not so much the disease is different, it just has a different name depending on your age.
Yeah, and the problem, I mean, we actually now coding with the adult coding, but they still, because obviously when they see it's a child, they'll classify it as juvenile rheumatoid, but it's the same adult code, the MO 6.99, which is the same code for rheumatoid arthritis. But again, like the whole criteria changes in terms of how they're funding. I mean, you and I have spoken about a lot about this frustration around it. Yeah, I mean, the funding is exceptionally frustrating. And unfortunately, it's not getting any easier. This year has been rough from a funding point of view.
Yeah, it's getting harder, unfortunately. Yeah. Thank you, Shehnaaz.
Thanks, Kath. And thanks for all the work that you do.
Sure, of course. Fighting medical aids. There we go. You're welcome.
So there are a couple of questions coming through on the chat. There's one from Claire and one from Nicola, but Daimani puts their hand up first. Daimani, are you there? Can you tell us what you want to know? Where are you? If you can off mute. I'm going to try unmute you, Daimani. There we go. Okay.
Can you hear me, Laura?
Yes. We can hear you now.
Okay,
Hello.
yes. I just want to ask from Dr. Shehnaaz that my daughter Olotando is always complaining about the hands. She's always having shaking hands. I don't know either it's because of the treatment or it's because of JIA. So if doctor can also assist me, if there's anything that I can also give Olotando since the treatment is also having the after effects.
Thanks, Daimani.
Hello, Mrs. Daimani.
Mrs.
Thank you.
So we know that, I mean, specific, like the shaking of the hands shouldn't be linked to either the arthritis or the treatment. But we know that painful hands or swollen hands, or uncomfortable hands, so you make them, can firstly get worse in cold weather in winter. And so especially now the temperatures like have dropped quite quickly. So I would advise like being strict about wearing gloves, keeping her hands warm. But we also need to make sure that there's no like side effects of the medication. And so that's why we regularly do blood tests to make sure there's nothing abnormal in terms of the chemicals, the salt, the sugar in the body. But usually the juvenile arthritis wouldn't cause shaking of hands. And we would have to look a bit deeper into what the shaking of the hands are. But if you're moving your hands a lot because it's uncomfortable, then that means that there might be inflammation still in her hands, and so we'd have to look a bit more into her hands and make sure there's nothing that's causing the inflammation in her hands, but also make sure there's no side effects. But the medication most of the time wouldn't be explaining the shaking of the hands. We also know that with having lots of pain, being on medication that is painful, if you're having on medication that's an injection, sometimes children exhibit anxiety in a different way. Like they show their anxiety, whether it's pain related or whether it's fear of the needles, whether it's just having been through so much with injections, and they show the anxiety with different movements as well. So that's also something that we need to make sure that Olutando is not experiencing, is anxiety and stress. And it's difficult to, we need to, get maybe a psychologist involved, or even the school, their counselor, to just see if there is a level of anxiety. Because shaking of hands is not really linked to arthritis.
Thank you very much, Doc.
No problem.
Thanks, Mrs. Daimani. Thanks, Shehnaaz. There's a comment from Claire who said, "Thank you for this. I've recently received the diagnosis of SJIA for my 10-year-old daughter." Thanks, Claire. And then Nicola asked, "Is there a link between lymphoma and JIA as a future diagnosis or related?" She says, and Nicola, you're welcome to ask the question yourself. Okay. She says, "My mom was diagnosed and they were asking if there was any autoimmune disease in the family, just checking if there are genetic links." And she also asked if it's related to Epstein-Barr virus, or how it's related to Epstein-Barr virus.
I'll just sort of add quickly, but thank you. I think that was pretty much it. But I know the EB virus can sometimes be linked to the onset of lymphoma, and it also seems to be something linked to the JIA. And just when my mom was diagnosed, something they asked was if there are any autoimmune diseases in the family. So it's just interesting to know, is there more risk in the family? Is it something JIA kids are more at risk to later, or is it just something that there's a bit of it, it's all sort of autoimmune related, but it's not necessarily linked?
Yeah, great question. So with regard to lymphoma, and definitely Epstein-Barr virus has a strong correlation with the lymphoma. Yeah. The link between juvenile arthritis and Epstein-Barr is often not an obvious link, in that we don't even, it's not even part of our testing panel, but we know children who have Epstein-Barr virus can have arthritis.
Do you
So
think that the immune response is so strong to both of them that it brings that it's like the onset of that triggering the cells to
yeah, but the thing with
and
Epstein-Barr virus as well is that lots of us are probably exposed to it anyway. So it's a
mm,
very difficult thing to say again causatively is the cause of juvenile
yeah
arthritis, or actually lots of, I mean, um, at Red Cross, I've sometimes worked in the transplant units, and they're often screening for Epstein-Barr virus for children who've had
mm,
transplants, because it's something that's just quite insidious. It's also another virus called CMV, cytomegalovirus, that for most people you may be exposed, there won't be anything, but for whatever reason, again, a combination of the immune system, genetics, if your immune system is low, so babies developing who get the CMV virus can be sick. So certain population groups are at risk, but there's no specific correlation between Epstein-Barr virus and juvenile arthritis. The link with Epstein-Barr virus or CMV is more they can have a reactive arthritis that
mm,
settles. So it's
mm,
not like the cause of a
mm,
juvenile arthritis. The link between lymphoma and autoimmunity, and I suppose maybe because our kind of, we're looking at children up until 18, 20, and then, there obviously are studies tracking children like later on. But also the diagnosis of kids, obviously, over the last 20, 30 years has gotten better. So we don't
mm,
probably have as much long-term data. Certain autoimmune conditions in adults do predispose to some sort of cancers. So
mm,
there's the condition called dermatomyositis, that the adult form, one of the subtypes has a higher risk of some certain type of cancer, but the pediatric form, we don't see that same thing exhibited. Similarly, with when you're on Humira, if you look on the Humira website, they often have, I think at the one point they had a big block about it. There's a link to a certain type of leukemia. And
yeah
again, we don't see that in pediatrics.
mm,
We and obviously I think we probably start patients on it sooner than the adults do.
mm,
It may also be this body in a state of inflammation
mm,
acting oddly,
mm,
predisposes you to your cells being also like going rogue essentially, and making
mm,
and replicating. So there's
yeah
definitely no clear link between juvenile arthritis and lymphoma or leukemia.
yeah
But we do know, obviously, an immune system that's disordered
yeah
can have both autoimmunity as well as immune deficiency. So that's another thing we're finding a bit more is, with more studies that are being done and more children that are coming with immune deficiencies, we know that a dysregulated immune system sometimes also puts you at risk of autoimmunity. But these patients with our studies are a lot more genetically, like they're almost, we not us here in South Africa, but in the US and in Europe, they are able to a bit more genetic studies and actually pinpoint those type of patients who have the combination of immune deficiencies and autoimmunity. But obviously the immune system is so vast.
mm,
I was
mm,
actually at a conference, the SARA conference, and I spoke to one of the professors of immunology, and I was talking about this testing about genetics. And I was like, the panel is so big, like, shouldn't we rather, instead of doing all these other tests, shouldn't we rather do the genetic panel? And he said that currently what's available is 500 genes. So I was like, well, that's quite a lot of genes. And he's like, you probably, though, the next a panel that's around the corner is about 3,000 genes.
yeah
So, we just like, maybe the picture
so,
changes in the next 10 years. And that's kind of what's also really happened with our treatment in the last 20 years. Juvenile arthritis the face of juvenile arthritis has changed. So when the prof who kind of trained me, Professor Scott, when he first started, they really had to get the physios involved and the OTs involved in the clinic, because the children had and the word doesn't sound nice, but they had deformities. They had, real problems in joints and were wheelchair bound. And just the other day, Dr. Webb and I were saying, actually, we don't really see the physios in our clinic, because we're able to diagnose it quicker, because we don't really at this point need them. I mean, we do need them, but we don't need them like actively in the clinic. What we do need them for is to give us cool exercise plans for our kids. Actually, that's actually what we want to do, is we want the kids to actually be exercising and moving and stuff, but we're needing them for a different role, not to release joints or get mobilization going or get them out of their wheelchairs. And that's also with the advancement of treatment. So that's why it's such an exciting field, because the more we're understanding about the immune system, the more we're able to target our therapies, and hopefully settle this, and provide children with a better quality of life and a normal quality and normal life with treatment.
Thank you.
No problem.
Thanks, Doctor. Thanks, Nicola. If there aren't any more questions, I'm going to close the Zoom meeting. Anyone else? Okay. Thank you. Dr. Shehnaaz, thank you so much for making a complex disease and set of circumstances much more easier to understand. You've made the condition feel a lot clearer for me, and I've learned a lot. Thank you very much. And I think we need that to feel like we are able to manage better as families taking care of our kids. So we really appreciate your time and your expertise and your knowledge on this, and sharing all of it with our community.
Thanks.
At 9 o'clock at night.
Thank you so much.
All right.
Thanks
Have a good
very
evening.
much. Thank you, everybody.
Thanks,
Bye.
Dr. Shehnaaz.
Take
Thank
care.
you.
Thank you. Bye-bye.